Okay, we'll go ahead and get started. So thanks everybody for joining us today. We're going to talk about the persistent topic of Medicaid redeterminations that continue to be looming with the end of the public health emergency. I'm Sara Ratner. I'm the Senior Vice President of Government Markets and Strategic Initiatives at Icario. Just a little bit of housekeeping. If there's questions, please include them in the Q&A section. I won't be able to check and go through this presentation at the same time. I'm not that talented, unfortunately. So I will answer questions at the end. So today's agenda, we'll talk about a couple of different things: the updates to the public health emergency guidance, some approaches to mitigate churn, as well as how to help members and beneficiaries transition coverage once the PHE ends and there are beneficiaries who disenroll. So to set the stage, we all know that Medicaid has grown substantially through the public health emergency. Enrollment is up 25% over pre-pandemic. And pre-pandemic growth was really anticipated at only about 4%, and I think that's fairly aggressive. Of the 25%, 16% is the baseline growth, and then 25% is maintenance of eligibility growth. So clearly a huge portion of people that were impacted by the public health emergency continuing to maintain their coverage during this pandemic. So as CMS has written and spoken about this, they have outlined several approaches that they are using in the unwinding or recommending to states as part of the unwinding process. So states can prioritize cases based on the length of time the redeterminations have been pending. They can prioritize populations based on eligibility segments, so those that are more likely to become ineligible, or they can use a hybrid approach, which is probably the one that will be the most common. And the hybrid approach involves renewing early those individuals for whom the state has more current data, or enrollee provided information that indicates that they're no longer eligible for Medicaid. Can also be timing the renewal of people who are turning 65 so that they can transition more seamlessly to Medicare coverage. Any approach that the state uses has to encourage keeping those eligible for Medicaid enrolled and those ineligible transitioning for coverage. CMS has said this in most of their notices and letters. And also the transition must meet the 12-month timeframe. We'll go through a couple of updates to the public health emergency and guidance that's come out from CMS in the last couple of months. As we all know, the Biden administration has announced that it will give 60 days notice before the public health emergency ends and 12 months to unwind. So no disenrollment can occur until the PHE ends. And since there are fewer than 60 days before the end of the current PHE declaration and no notice has been given, it's almost certain that the PHE will be renewed again. And it will take place in mid-July and extending the continuous coverage requirement through October and possibly beyond. And to the extent that CMS extends it past that, that would occur roughly mid-October. And continuous coverage would be until November 1st. And then if it extends it again, the end date would be January 11th, 2023, and so on and so forth. So lots to be determined in terms of when this will be extended and for how long. So states will be expected to develop an unwinding operational plan, and they will most likely, and we're seeing it start to begin, push this down to health plans in order to operationalize. States will have 12 months after the PHE to complete the post-enrollment verifications, redeterminations based on changes in circumstances, as well as renewals. And as CMS said, it will consider a state in compliance if it has a couple of different components. First, it's initiated all renewals for the state's entire Medicaid and CHIP caseload by the last month of the 12-month unwinding period. And it's completed all of these actions by the end of the 14th month after the public health emergencies end. So states have to initiate a full renewal for all individuals during that 12-month unwinding period, even those for whom they've already conducted a renewal during the PHE. So some states have gone through and said, if the PHE was not in place, who would be ineligible, who would be, and while they could not disenroll people during this period of time, they still cannot renew that determination until the PHE is lifted. So CMS recommends that states do no more than 1/9 of the total caseload of renewals in a given month when the PHE is lifted to mitigate the risk of churn. And we're seeing this right now with staffing for call centers and using alternate means to communicate with individuals, because there is concern that there's going to be such a heavy caseload that call centers, Medicaid areas, departments have to take on, that it's gonna overwhelm the system. And so there needs to be other approaches that take place in order to help mitigate some of this overload, and we'll talk about them. Also, what we found is that some states, as everybody on the call likely knows, have filed 1115 waivers that allow guaranteeing Medicaid coverage for 12 months after their eligibility determination, regardless of the changes in income. So we have to keep that in mind, that also this automatically does not stop once that determination has been made. And that's roughly 34 states to date. So what actions does CMS say that we should be taking right now? They have broken the unwinding process into 2 phases. The first phase is prepare and educate. It's so important to make beneficiaries understand and give them notice that this is coming, especially because there is such a large number of people who became eligible for Medicaid during the pandemic that may not have been eligible before. So they are unfamiliar with the redetermination process and what it means, what it looks like, and how do they go through it. Phase 2 is the actual coverage renewal, where the beneficiary is communicated with, take the necessary steps to renew their coverage or to transition to other coverage if they are no longer eligible for Medicaid. So we're in phase 1 right now. What does this mean? It means a lot of different things. The first and the most important, and where we're seeing heavy investment, is making sure that contact information is updated. This is absolutely the most critical thing right now, so that when the PHE is lifted, states and plans can start sprinting and execute on the strategies that have been developed in this waiting period. And then also education. As I mentioned, a lot of beneficiaries are unfamiliar with the re-enrollment process. And so giving them the requisite education about when this will begin or when it's anticipated to begin, what it means for them, what it means for their kids, and the action that the beneficiary will need to take. And it could be something as simple as you may have to re-enroll in Medicaid in the coming months. And here is where you get more information to do that. So driving that awareness around what this means and the impending action that they're going to have to take is really important. As part of the preparation, it's important for plans to do a couple of things in terms of stratifying their risk and mitigating the risk for beneficiaries losing coverage. The first is to look at their populations and stratify for those who are at risk for gaps in care due to loss in coverage. These are going to be the greatest, these are going to be the people at greatest risk around losing their health care and having adverse consequences or effects from not getting the care that they've been receiving during this period of time. Also, understanding who's going through a course of treatment and may need that transition support. So somebody who is getting cardiac care, somebody who has cancer, those types of courses of treatment require that persistent care that can't just end. And so understanding and communicating what that looks like and how it's going to be approached is critical for that member to understand what they should be doing. So when they do receive that notice that, the disenrollment could be coming, or they have to go through a re-enrollment process, that they know what it will look like to continue the care that they're currently receiving. Pregnancy may be treated differently by state, so it will be important to understand if there are extensions for pregnant and postpartum mothers. And states and plans also need to really focus and hone in on the communication needs of these populations. They are diverse and highly variable, and so communication based on race, cultural barriers, ethnicity, these have a high correlation to engagement if you communicate in the right way that's relevant to that population. And so stratifying the population and understanding from a series of data sources how to communicate, what the message needs to look like, and the speed and cadence is critical to effectively execute on this transition. And also some populations may need a longer period of time. So it will be critical to work with the state's outer bounds for when a person needs to renew, to give that beneficiary enough time to respond. So there's a couple of different things that have happened over this period of time. And I'll mention a couple that have occurred in March, April, and May. So in March, CMS released a state health official letter clarifying the expectations for unwinding. And part of this letter addressed updating beneficiary contact information. And so what this letter basically said regarding updating contact information is a couple of things. First, the states may update the beneficiary record with the new address if the state sends a notice to the address on file with the state and provides the individual a reasonable period of time to verify the accuracy of the new contact information. So this is a requirement for the state. And I'm stressing that for a reason I'll note in a minute. States are also encouraged to contact the member through different modalities, such as telephone, electronic notices, text, email. It really stressed the need to have this multi-channel approach and not use something that has been static and stale and unsuccessful way to engage this population. And then if the beneficiary confirms the new contact information on file with the plan, the state may then update that beneficiary record with the new contact information from the plan. So essentially, it's the state, not the health plan's responsibility to verify the accuracy of the contact information. And this is important because if a health plan is sending out messages to its members, it can use certain data that it gets from third parties. However, the state then has to go back and verify that accuracy when it receives the file from the health plan. And something we're also seeing is that some states are using 1902 E14 waivers to receive and use updated contact information from the health plan without the notice to the address on file. These are not publicly filed. And so it's going to be on a state-by-state basis on whether or not and how they communicate using the 1902 E14 waiver. So in May, shortly after CMS released the state health official guidance that I previously went through, the House Energy and Commerce Committee Chairman Frank Pallone and Senate Finance Committee Chairman Ron Wyden wrote to a handful of companies contracting with the states to assist in determining who is eligible for Medicaid and CHIP coverage at the end of the public health emergency. And the committee was really concerned about the financial incentives provided to these companies that may result in eligible beneficiaries actually losing coverage if the company's compensation is based on the number of disenrolled. And so the committee then went on to write this letter to these companies and requested information from these various companies that included a detailed description of the business relationship with the state and a copy of the contract, a detailed description of their experience, the organization's experience in working with state Medicaid agencies and specifically assisting with Medicaid eligibility determinations or any portions of the determination programs. So they really want to understand that these contractors know this area, understand the beneficiaries, understand the dynamics, and know how to execute on these programs. And then the third is the committee requested a detailed description of the organization's capacity to perform the tasks the company has been contracted to perform. So can it take on 500,000 beneficiaries in order to help communicate transitions and coverage? Those are the questions that the committee has put out there. And we haven't seen any formal responses yet, but we suspect that they're going to continue to add to this list, especially for those companies where there could be financial incentives that are misaligned to keeping people enrolled in Medicaid to the extent that they remain eligible. So a interesting wrinkle has transpired that causes the redetermination programs to intersect with TCPA. So in April, with the continued focus that we've been seeing on engaging beneficiaries around re-enrollment, HHS and CMS jointly requested the Federal Communication Commission's opinion on whether certain communications around re-enrollment are permissible under the TCPA, so the Telephone Consumer Protection Act. And this has been a focus in healthcare over the course of many years in terms of how people can communicate with members and beneficiaries. So just a little bit of background on TCPA. Under this statute, all non-emergency calls, which include text messages played through an auto dialer or using a pre-recorded voice, require some form of consent if placed to a wireless number, with the form of consent dependent on the nature of the call. And so when people have been reticent in the past about texting members, the genesis is usually because of the interpretation around TCPA. So TCPA makes it unlawful to initiate an auto-dialed text message or a call to a wireless telephone number without the member's prior express consent. And in certain circumstances, this has placed constraints around how we outreach to members and what we can communicate. However, I will say that non-auto-dialed messages, such as healthcare messages, do not require the recipient's consent if the message in question is informational in nature. So what does informational in nature actually mean? It means HIPAA-covered calls. So if a health plan is communicating about treatment payment or healthcare operations, that's an informational message. So most messages in healthcare do fall under the informational message component, not requiring the member's consent. So for healthcare calls, if consent is required, the consent is usually collected during the enrollment process. So when a member goes to sign up, what we found is that they typically have to sign terms and conditions and various disclaimers as they go through the enrollment process or eligibility process. And that is sufficient in order to get any prior consent necessary to the extent a plan feels that it is necessary. But I would continue to purport that that these messages are not typically delivered by the way people have defined an auto dialer. And so for the most part, really do fall outside of the TCPA. And so this becomes relevant again, going back to the joint HHS and CMS letter, because they both requested an opinion regarding whether certain text messages and calls for the purposes of redeterminations, re-enrollment, are permissible under TCPA. So both agencies asked for confirmation on the ability to outreach to members in several different scenarios. So the first is that the state and federal government employees who send these messages are immune from liability. It's derived from the sovereign immunity that states have in most cases. That state and federal contractors who send these messages, when authorized by the government agency, are also immune from liability. And where a state government agency has delegated this authority to determine eligibility for Medicaid, so those people who qualify, the local government employees who deliver these messages to individuals generally be immune from suit under the TCPA, as will its contractors when the local government entity authorizes it. So continuing to extend this sovereign immunity downstream to the state, the contractors of the state, and then the last is those health plans providing coverage to Medicaid enrollees under contract with the state that deliver these messages to individuals will also be immune from suit under the TCPA, as will their contractors. So health plans, CMS and HHS ask that health plans are also able to get the benefit of the state's sovereign immunity for purposes of limiting TCPA liability for redeterminations. And we're actively monitoring the FCC's response. As of this morning, we haven't seen anything, but we do anticipate a response shortly, especially before the expiration of the PHE, or the impending expiration, I should say. So we'll transition a bit to how do plans mitigate churn during this process. If you look at or read various earnings statement transcripts or listen to earnings calls, this is a central focus for many plans. And some actually go out of their way to project potential churn, while others are more bullish in how they expect to benefit from churn that may take place. And Happy to follow up offline with any of those different transcripts as we continue to track them and the guidance that's released as part of it. So surveys estimate that between 5.3 and 13 million low income could lose coverage at the end of the PHE. That's a huge variance. And that's all we have right now. I continue to see roughly 13 million floated as the number. But I think as plans and states continue to hone and refine their strategies, this will be a lower number, hopefully. Separately, another survey found 13% of Medicaid enrollees will be disenrolled as well. And then third, a MACPAC report estimates a high number of people will churn on the expiration, so 8%. All of these represent statistics that we need to continue to focus on. How do we limit the churn? And it really does go back to the two-phase strategy that I described before, the first of which being communicate, educate, and also make sure the contact information is the most accurate and up-to-date so that when outreach does occur, it will be to the correct member. So the first strategy to really help mitigate churn is, as I said, shore up the contact database. This involves identifying those stakeholders who actually help pull that together. Which companies do you work with? Where are the data sources that you pull from in order to get this information and make sure that it's the most up to date? What we found happens at times is that there is contact information that when the plan receives gets overridden by other contact information. So it actually works against, meaning that the updated contact information or the new file is actually more outdated than what's in the system. So making sure that that data integrity and fidelity exists with the most updated information that's being received, and it's not inadvertently being overridden. The second is building trust. We've all experienced those messages, those text messages, the phone calls where we think it's spam and we turn off. And continuing to communicate with members through this period helps to build that trust. So it's not receiving one message and then, moving on. They need to receive a series of messages so that they know that the initiator of the messages or the health plan can be trusted, and what they're saying is actually something they need to be concerned about and taking action on in the future. So the messages need to be staged. So a building of these messages, starting simple and then progressing through a series of education to what it means to that member. And this helps foster that trust. We found that in studies we've done, the more we communicate with members, they are more likely to respond because they understand if they get a phone call that the text message that they received was a notification that that phone call is coming, and that helps them actually, for example, answer it. So that communication of expectations helps to drive the engagement that's necessary. And also, carpet bombing doesn't work. So I'm not suggesting that. It's really a cadence of outreach that makes sense to that member, who they are, where they're at, how they like to be communicated with. But that cadence has to be regular in order for them to realize that they need to take action. So we all hear that people need to be told something 5 times to actually learn it and remember it. It's the same thing here. People need to hear a constant message of what's going to be coming and what they need to do. And then multiple modalities. As CMS mentioned in the state health official letter, using different modalities is critical. We've spoken with states who say they're only going to use paper and expect that the disenrollment rate will be rather high. And so that is why there's so much activity to say, can we reach out to members in these various ways using multiple modalities so that it is easier and more successful to get in front of the members and get them to understand what's coming. And then the third is to track results and preferences. So plans should continue to hone and optimize around which channels and approaches work best. So there may be two text messages that go to a member where there's no response if they're being asked to respond, or we understand it's not going through. That then needs to be flagged, and the approach needs to pivot to something else until the modality and the approach resonates and is successful. And as I mentioned, you know, carpet bombing is not successful. Nobody likes it. So limiting abrasion and using that calendar approach is a really successful way to help make sure that we're limiting abrasion and minimizing the noise. So Icario has helped plans in this area, and I figured I would give an example of how one plan is taking action and the approach that they're using. So in anticipation of the PHE expiring, one of the health plans that we work with wanted to start reaching out to its members in order to take a proactive approach in the way that we've described. However, in the past, in working with them, we understood that there are several challenges in engaging these members and really doing that deep dive of what has prevented engagement in the past is a critical question and component to address before outreach starts to begin. So a couple of things that this plan ran into: bad addresses, members with limited English proficiency, and members who are new to Medicaid post-COVID. All of those can be addressed. So for example, bad addresses can be addressed through making sure that the contact information is the most up to date. Members with limited English proficiency, understanding who the members are, layering demographic data on top of the population so that you understand if there's a pocket that has a particular language need and you may need to shift your approach around how that members communicated with. An example that occurred for us is we were communicating with a group of members in a borough in New York City and kept measuring this and using our propensity modeling and different approaches to help drive engagement. And we were stumped at why we could not drive engagement. And so in peeling back the layers, we found that this population, there was a high degree of people who were Polish speakers. And so once we were able to shift and pivot quickly and send out messages that were in Polish, we saw engagement skyrocket, but only because we layered that data on top of it to really ask the question of what is going on? Where are the barriers? This is the same thing with people who live in a broadband desert. If the plan is looking to send out text messages and we know that people don't have the FCC's minimum broadband speed, it's probably not useful to take a digital only approach. And so layering on live agent or mail will be important as that population presents itself with limited broadband. So several strategies that we deployed: multi-channel outreach, as I mentioned, leveraging many different data sources for this contact information. And then the messages should also be tailored based on the needs of the population. So separate from addresses or LEP, there may be certain social determinant of health barriers that we know members are facing. And so some of those will influence an individual's receptivity to getting this message and actually understanding it. So looking at your data from other places in the organization or external third-party data to say, what is manifesting in this population? What are we seeing? And asking the question of how will this impact redeterminations is really important, especially right now when we have a bit of time to exercise going through the updates and making sure that everything that we've put together is the most relevant and the most successful for reaching out to the population that's targeted. So the third area I will briefly touch on is transitioning beneficiaries between coverage. And to me, we're not seeing enough focus around this right now, and I think there can be a lot more. And the reason for that is because the impending PHE expiration, there's so much to do around that. But we're seeing more and more states take a proactive approach in how they're thinking about transitioning beneficiaries. So states and plans will need to develop these coordination strategies to bridge the redetermination transitions. And these include a couple of different things: coordinating with the local entities, including exchanges, to help smooth coverage transitions and minimize the loss. In 67% of counties and for 81% of the population, health plans provide both marketplace and Medicaid coverage. So I falsely assumed that it would be difficult to transition members because there would not be that overlapping coverage. Not the case. There's a huge overlap between marketplace and Medicaid coverage. An estimated 1/3 of those losing eligibility for Medicaid will actually be eligible for subsidized coverage with the marketplace. So it's false to assume that these people are going to have to go out to the market and pay for very expensive premiums. It's important to reinforce to people in the messaging that they may qualify for subsidies, and the subsidies may result in them paying a very nominal amount for coverage. Plans should also reinforce important messages such as, that coverage that's affordable and comprehensive is available if they no longer qualify. And what we found is that 4 out of 5 enrollees can find plans that cost less than $10 a month. So members knowing that and understanding that that is out there, that they have the option to transition to a marketplace solution that is very inexpensive, instead of making the choice to be uninsured completely, is critical. And then these plans have coverage for prescription drugs, doctor visits, urgent care, hospital visits. So it's obviously not stop-loss coverage. It's really, it's great marketplace coverage, and reinforcing that with members is an important message. So the last thing I'll touch on is, how do members actually take the steps to transition to a marketplace solution? And outlining this in an elemental way, easy to understand, is important in setting the members' expectations on how do they progress through this process. So updating contact information, How do they go through re-enrollment? If they don't and they're disenrolled, what happens when they engage in a marketplace solution, and what should they expect, so that this is not foreign to them, that they have a understanding of what steps they need to take in order to successfully transition. So the first is just notifying the consumer, the member, that they have a window to apply for marketplace coverage, and that they may receive premium tax credits for this. The marketplace then will review and confirm ineligibility for Medicaid, so making sure that this member is no longer eligible, and verifying that they now can be a marketplace beneficiary. After that, the member or the consumer will receive the determination on whether they are eligible for the tax credits. And then they will use the marketplace tool to compare and select the right plan, and ultimately with the member enrolling. This process, instead of communicating to the member that, okay, you can go find a marketplace solution, this process helps to minimize angst, continue trust with their current health plan, that they're taking care of their member, even if they're disenrolling from that plan at that point in time, and knowing what reasonable expectations are, so it's not scary, it's not daunting, and they don't just throw up their hands, is a really important component, the last component, for how do we effectively transition these members, these beneficiaries, in whether it's to re-enroll in Medicaid or to transition to another plan, whether it's marketplace or Medicare. So with that, I know we have about 15 minutes, and I can open it up for questions if there are any. Yes, I'm happy to share the slides at the end of the webinar. Other questions that I can answer are things that I can clarify. And I believe you all have my contact information in the event that you want to reach out personally and separately and don't want to ask a question here. Happy to take questions offline as well. I think Danny or Icario can send around my contact information if it's not already out there.
Sarah, I think there are some questions underneath chat.
Yes. Yeah, so the 1902 E14 waiver, it's kind of an antiquated waiver that is not used terribly often. And states are starting to recognize that it can be used to allow updated contact information that is not verified with the beneficiary, and leverage that waiver as part of it, because the waiver really goes to getting people to enroll in coverage and supports the enrollment process. And so this component being one of them. I don't have a list of those states that have filed those waivers. It's not public, but we're monitoring with our clients which ones they've been told have been filed with the states. Any other questions? Well, thank you everybody for joining. Oh, I keep seeing messages. Okay, I think that is all the questions. Sorry, I'm not able to multitask very well. And yes, we will send around the slides. So thank you everybody for joining today. Please feel free to reach out to me or anyone at Icario with questions, and good luck with this process that we're about to confront. So have a good day, everybody.